Okay, let us now talk on the investigations or tests that we do for patients with coronary artery disease. Now, whenever we do tests, it is important to keep in mind why we do these tests. For coronary artery disease, the aim of doing tests or investigations is to assess the severity of the coronary artery disease. How badly does it affect the life of the patient? What can he do and what he cannot do? It is also important to determine the prognosis for the patient. What is the outlook? What are the transfers for hospitalization or death, for example? We also are interested in the complications of coronary artery disease. Has the patient had bypass? Will he need bypass? Has he had heart failure? Is he going to have heart failure? And these are also all important questions that our test will help us to answer. At the same time, we should remember that there are risk factors for coronary artery disease, and all these risk factors can also give rise to complications and damage on their own. So what are the tests we should do? Well, we start off with the blood test, and the hemoglobin is very important. This is because if the patient is short of blood, red blood cell, if there is anemia, the effect of the inadequate blood supply to the heart is worsened. The oxygen carrying capacity of the blood is less, and any little block will be felt more. Similarly, the white blood count and platelet counts are important because they tell us whether the patient has an infection. Any form of infection increases the oxygen demand and will show up coronary artery disease more. We also must look at the renal function because diabetes and hypertension, two important risk factors for coronary artery disease, both will give rise to kidney disease. Similarly, liver function is useful because in heart failure due to coronary artery disease, then there can be liver congestion and liver malfunction. The lipids are important, and in particular, the total cholesterol, HDL cholesterol, and the ratio of the total to HDL cholesterol. These are important risk factors for coronary artery disease, and they will predict the future risk of getting worsening coronary artery disease. Now, should we do a fasting lipid or a non-fasting lipid? The reason why we do a fasting lipid is because the triglyceride level is affected by fasting, and the LDL level is calculated from the triglyceride level. So in the fasting state, then we are able to calculate the LDL level, and many authorities uh, cite LDL target levels for us to reach and for us to begin treatment from. So if you want to calculate the LDL level, then you need fasting lipids. However, total and HDL cholesterol level are not affected by fasting, and so even in the non-fasting state, you are able to work out the total HDL and the total HDL ratio of cholesterol. Now, glucose is important to diagnose diabetes, and there are parameters for the fasting glucose and for the 2-hour postprandial glucose, which will tell us whether a patient is diabetic, has impaired glucose tolerance, or is normal. Similarly, the HbA1c level will also help us determine whether a patient is diabetic. Thyroid function is important because a hypothyroid patient can have elevated lipid levels, while the hyperthyroid patient will have tachycardia and increased oxygen demand, and so making the patient feel more the effect of angina. A microscopic examination of the urine is important to look for hematuria and proteinuria, or the beginnings of proteinuria, albuminuria, because these are conditions that will tell us how the renal function is like. Now, it is also useful in the appropriate patient to look at the cardiac troponin, which are cardiac enzymes. There are other cardiac enzymes, and when you look for cardiac enzymes, it is because you are interested in finding out whether there has been death or damage to the cells in the heart. If the myocardial cell is damaged or died, then it releases its enzymes, and if you want to diagnose a heart attack, a myocardial infarction, you must show that the enzymes rise and then fall, or they are They begin at a high level and then they fall over a period of time. A dynamic change in cardiac troponin or enzyme level will diagnose a patient with a heart attack. There are other non-ischemic causes of myocardial damage that can give rise to elevation of cardiac enzymes. Elevation of cardiac enzymes show damage to the heart cell, and while most often it is due to coronary artery disease, there are also other conditions that can cause it. The preferred cardiac enzyme to use now is the troponin, and there are three different types: troponin P, troponin I, and troponin C. And now we have progressed to the high sensitivity troponin T level. Remember, there are many non-cardiac sources of elevated troponins, and these are some of the many conditions that can cause it. So you always have to remember the patient and the appropriate clinical condition whenever we do tests. Traditionally, we use the creatinine kinase or the NB fraction of the creatinine kinase as the cardiac enzymes. And there are three traditional enzymes that we use: the CK, the SGOT, and the LDH. And they rise sequentially, first CK, then SGOT, then LDH. However, these three enzymes have even more non-cardiac sources and lead to a confused picture when trying to diagnose a heart attack. For example, CK comes from any muscular part of the body, SGOT also comes from the liver, and LDH gets elevated in any form of lung disease. A CK relative index, that is the ratio of the NB fraction to the total CK, will provide a more accurate indicator of whether the CK comes from the heart. And if the NB fraction is elevated and the ratio is more than 5, then it is more likely that the patient's condition is due to the heart. Now, the ECG is a very useful tool. It is an electrical representation of the heart. We stick wires to the chest, and from the electrical activity as recorded by these wires, we are able to tell the condition of the heart. Ischemia is shown by ST depression. And if there is more than 1 mm ST depression, especially if it is downsloping, then we are concerned about the presence of coronary ischemia. Whenever we do an ECG, we group them because groups of ECG leads look at the heart from the same position. For example, leads 2, 3, and AVF look at the heart from the bottom, the inferior part of the heart. Leads 1, AVL, V4 to 6 look at the side of the heart, the lateral part of the heart, and leads P1 to 3 look at the front of the heart, the anteroseptal part of the heart. So whenever you're reading an ECG, remember to look at groups of leads together. You do not look at any one lead, but you look at groups of leads together to try and form a conclusion whether the heart is abnormal. In addition to ST depression, you also look for T wave inversion and U wave inversion to diagnose coronary disease. So remember that the upsloping ST depression is not so bad. The downsloping is bad, as is the horizontal ST depression. And looking at the ECG here, you can see that there is ST depression very clear from V4 to 6. Also in lead 1 and to a lesser degree in AVL. So this is a patient with ischemia, especially in the lateral part of the heart. Some ischemia also in lead 2 AVF, but most prominently in the lateral part of the heart. Now, a myocardial infarction will produce sequential ECG change, beginning with a tall T wave, then there will be a ST elevation, and the Q wave develops. The myocardial infarction is a condition where cell of the heart is actively dying because there is not enough blood flow, myocardial cell dies, and so the ECG change is dynamic. It changes with time. Here you can see, for example, the tall T wave from V4, V5, and V3, and this is then goes on to be shown as ST elevation. So these are the changes of tall T wave, then ST elevation, and then the development of Q waves. So they all come one after the other. And of course, in the real life situation, they can come uh, in different leads and be merged together. So when you see any ECG change in a particular place, you can have reciprocal changes elsewhere. For example, ST elevation will come with ST depression in the other leads. Look at this ECG again, and you see the tall T wave from V2 to V4 with the ST elevation from V1 to V3. And together with that, you get ST depression in V5 and 6 and in the inferior leads. So when you see changes in particular leads, there can be reciprocal changes elsewhere. And of course, you will be told more about this in your tutorial on ECGs. Now, there are also other tests you can do for the heart. The stress test, for example, is to produce ischemia by working the heart more. The harder the heart works to do any activity for the patient, the more oxygen it needs. And so if there's any shortage of oxygen, any blockage in the coronary arteries, it will be felt more. The stress test can both be diagnostic and prognostic. That means that it can tell which patient is at a higher risk of getting bad events in future. It can, of course, also tell whether a patient has coronary artery disease, and in particular, whether the discomfort the patient feels is from the cardiac condition. For example, if a patient complains of chest pain, but is able to run for 8 minutes on the treadmill with no chest pain, with normal ECG, then one can say with some degree of confidence that the chest pain is not due to the heart, because it is not seen when you strain the heart. The stress test can be done by walking and running on a treadmill, by riding a bicycle, and sometimes there's an addition of nuclear dye injection into the patient for these nuclear particles to light up parts of the heart so that you can tell the function of the heart and which part of the heart, which parts of the heart in particular are short of adequate blood flow. The echocardiogram uses ultrasound waves to look at the heart, and you can measure the systolic function, how well the heart pumps, and the diastolic function, how well the heart relaxes. You are also able to identify which parts of the heart cannot move because of damage or dead myocardium. And if you couple the echocardiogram with the stress test, then you are able to see which parts of the heart will malfunction when there is ischemia, but perhaps during resting conditions, the heart can be normal, getting adequate flow at rest, but having inadequate blood flow when the patient is exercising because blood is needed for other parts of the body. A CT angiography involves the injection of dye into the vein of the patient and then doing a CT scan of the heart. It looks at coronary anatomy, plaque amount, and hopefully even plaque composition. Coronary angiography means putting a tube into the opening of the coronary vessels, injecting dye to see whether the coronary artery itself has any obstruction. We are able to do MRI of the heart to look at its function, the perfusion to the heart, and the viability of the muscle. The intravascular ultrasound of the coronary artery can also be done, and by that, you are able to assess the plaque size and structure of the plaque. Remember what we said, that the structure of the plaque is very important to tell whether it is going to produce a stable or unstable condition. Now we come to treatment for coronary artery disease, and it is important to know what we are aiming for when we treat a patient with coronary artery disease. Treatment always has two main intentions. The first is to improve the symptoms of the patient, make the patient feel less pain, less discomfort. The second is to improve the prognosis of the patient. That means reduce the chances of a heart attack, heart failure, or death in future. So treatment is always symptomatic and prognostic, hoping to help the patient in these two important areas. At the same time, the risk factors for coronary artery disease also produce damage in other organ systems, for example, in the kidneys or in the neurological system. And so the treatment should also aim at preventing damage to these other organ systems. Treatment of this condition is always long-term because coronary artery disease will not go away. It is a condition related to aging, and so a patient would need treatment all the time. And since this is the case, lifestyle measures and drugs are very important because you need to sustain them. You intervened with cutaneous intervention like stenting or bypass surgery whenever the need arises, whenever a condition or complication develops that needs us to perform those. But after having the intervention, and drugs and lifestyle change must be continued. So this is the picture of how the treatment plan for a patient with coronary artery disease will be. Lifestyle and medical treatment is continued forever, and depending on the patient's problem, you can intervene with some percutaneous intervention or with bypass surgery. The correct choice at the correct time will allow us to help the patient. Now, medically, in terms of medicine, to relieve the pain and discomfort from angina, nitrates are useful. Nitrates can be long-acting, taken orally and then swallowed, or it can be quick but short-acting, meaning that it has to be used for absorption through the oral cavity. So a patient using short-acting nitrates should put it into the mouth, make it dissolve. Commonly we say under the tongue, but actually make the medicine dissolve in the mouth so as to be absorbed through the mucous membrane of the mouth, and then there will be a short, quick relief of the discomfort from angina. When using long-acting nitrates, it is important not to cover the patient for the whole 24-hour period, because then the patient develops tolerance to nitrates and the nitrates will no longer be useful. Beta blockers are an important part of the therapy for angina, and beta blockers work by reducing the heart rate, the blood pressure, the force of cardiac contraction, and so they reduce the need for oxygen from the heart muscle. Calcium antagonists are a wide range of medicines, ranging from verapamil, which is rather like beta blockers, working by reducing the heart rate and the force of heart contraction, to the dihydropyridines, which work by vasodilating. They open up and relax the blood vessels, therefore improving blood flow. Diltiazem is somewhere in the middle between the action of verapamil and dihydropyridines, and a bit more will be said about these calcium antagonists in the lecture on hypertension. Now, trimetazidine and nicorandil are two drugs that are very good for relief of angina. They do not reduce the chances of heart attack or death, but they are very good at making the patient not feel the discomfort from angina. For reducing future adverse events, for improving prognosis, reducing heart attack, and perhaps death, antiplatelets are very important, because heart attacks and death from heart attacks are due to platelet aggregation at the site of the ruptured plaque. So the platelets first come to where the plaque has ruptured, making the lipid from the plaque touch the blood, making a clot occur. Then, if we use antiplatelet agents, we can prevent the aggregation of platelets and therefore prevent the occurrence of heart attacks and acute coronary syndromes. There are two major classes of antiplatelets, aspirin and the P2Y12 inhibitors. P2Y12 inhibitors are more potent and therefore will be better at preventing heart attacks, but they will also be more likely to cause bleeding. Now, statins or cholesterol-lowering drugs are very important because they have been shown clearly to reduce heart attack and death for coronary artery disease. Whether they work by reducing cholesterol by plaque stabilization or even some other way through perhaps endothelial stabilization is a matter for scientists to debate and do research on. What we do know is that statins will improve prognosis and prevent heart attacks and death in patients with coronary artery disease. Again, beta blockers have also been shown to reduce adverse events in patients with reduced systolic function or after they have had a heart attack, and for patients with reduced systolic function and after heart attack, ACE inhibitors and angiotensin receptor blockers can also reduce future events. It is important in treating patients with coronary artery disease to remember to control and treat the risk factors and all complications arising from them. That means that we have to control the blood pressure, we have to control the blood pressure, the sugar, and lipid levels. When do we put in a stent with percutaneous intervention? Well, this form of treatment is very effective in reducing the pain from angina. If a patient has a heart attack, especially within the first 6 hours, then we should intervene quickly, because when we restore blood flow, we prevent cell death. So the treatment for an acute early myocardial infarction is with percutaneous intervention. Percutaneous intervention, while being very good in a patient with an immediate heart attack, for a patient with stable angina, will not reduce the occurrence of future heart attacks or death. Probably because the cause of angina is the stable plaque. The cause for heart attacks and death is the unstable plaque. Percutaneous intervention treats the stable plaque. Therefore, treating a patient with stable angina, with stable plaque, with percutaneous intervention will not reduce future heart attacks and death. Good for symptoms, not good for reducing future adverse events or improving prognosis. Now, it is very important that antiplatelets are given and continued in any patient who is undergoing and has undergone percutaneous intervention, because the stent, once put in, is prone to thrombosis, and if antiplatelets are stopped, a myocardial infarction can occur. Bypass surgery are good symptomatically and prognostically, and the higher the risk of the patient having future adverse events, the more quickly we must do bypass surgery. So bypass surgery is the treatment of choice in the high-risk patient who, for example, has left main stem disease. That means blockage of the coronary artery, where the left main artery comes up, because if the patient clogs up the left main coronary artery, then the patient is at risk of dying. Patients with poor left ventricular function or patients with diabetes who can have diffuse multiple obstruction will also do better with bypass surgery. Remember that after percutaneous intervention and bypass surgery, medical treatment and lifestyle changes have to be continued. Ladies and gentlemen, coronary artery disease is a disease of old age. This we know since the 60s. It is also a generalized disease affecting the heart, the central nervous system, causing stroke, the peripheral circulation to the legs and hands, and the abdominal aorta, causing aneurysm and renal artery disease. The plaque progresses from the 30s through the 40s, and so treatment of the disease has to be lifelong, with lifestyle and medical therapy and intervention as and when necessary. And with that, I thank you very much.